So,
We're gonna do that first, and that can be
Yeah.
totally good.
so, okay, so, there's my R, there's my N. So remember, your regular's your clear, NPH is your cloudy. The sequence is you put air into cloudy, then you put your air into the regular, draw your regular, go back and draw your NPH. Okay? So, say that you order 20 units of regular, 15 of NPH. So of course, I would have my imaginary little alcohol pads right there. So I'm gonna draw my air back to 15. Okay? Oh, thank you. You'll go home from the hospital with all kinds of things in your pocket, and that's usually one of them.
Yep.
So I'm gonna put, remember, it's air to air. So this is a little short needle. I know it's gonna go into air, not into the fluid. You're gonna take it out away from me, right? Then I'm going to put in 20 of air into the regular.
I got about 118 over 78.
Air. Then I'm gonna go ahead and draw my clear. The reason you don't start with clear with the air, if you draw your cloudy up first and come to clear, you might put a
She
little
did
cloudy
really. I
up
volunteered.
into clear. So I'm gonna go ahead and draw my 20 out. Remember, insulin syringes you can only use for insulin because they talk about units, not mLs. Okay, take it out away. Then I'm gonna go back. And what I'm gonna pull my plunger back to. I have 20 units of regular. 35, right. 35. I don't have to put air in again. I've already done my air. My 35. I pull slowly so I'm less likely to get bubbles. 2, 4, 5. Get out. When I'm ready to give. Never grasp up here and push down. I have seen these little tiny needles come out through this hard plastic. So you just kind of get it, put it back down, take it by the base right there. Because you can't walk through the hall with, Okay? I'll put that back on the cloudy. With the tuberculin. And I think some people this morning were going a little deep there because they were saying my bubble, I'm making a bubble, but my bubble's not staying. And I said, you're probably going too deep. I have a teeny syringe, but no, oh wait a minute, here we go. Oh, okay, good. Is that what you, yeah, that's exactly what I need, thank you. So.
Want one of these?
Has it got a needle, the tuberculin? Actually, I'm gonna use this one, cause that one, that little safety thing gets in my way. Okay, so you almost, remember with the tuberculin, you're not gonna put the needle all the way in. You're gonna have the bevel covered, pointing up, covered, and go just a little bit further. So now and I figured out something yesterday with left-handed. Anybody here left-handed? Okay. So right-handed, I typically come down like this, pull it apart.
I mean, it definitely.
If you go too deep, you're going just enough up under that you almost can see the bevel, but not quite. But you go in, I'm still got a little bit of the hole, and go just a little bit further, and then blow. Oh, I forgot to put air in there. Sorry. It's like a bubble without air.
How much would you want us to put with that?
Yeah. So the little bevel goes. Yeah, I just put like 0.1 in, just a little, and then right there. You can see the little bubble right there.
Perfect.
So I think some people were going too deep. Now left-handed, I think if you can, how did I do it yesterday? Oh, I did it like this. She was having a trouble doing this, and she was actually trying to figure out too deep. So we finally figured out for her, like if this is where she was gonna do it, come to the side just a little bit and use both of her fingers, and then she could still keep it at a low angle. Do it like that. I may not do it right since I'm not left-handed, but yep. So, either way, you gotta pull that skin some way so when you touch that skin with your needle, it doesn't move from side to side. But the art of the intradermal is not to go too deep. And really on a person, it's easier than this because the skin's not quite as flabby as this. That's really what you're looking for right there.
Oh, wow.
That's a pretty blend right there.
Yeah.
Yeah, but this skin, that doesn't, it's not as jiggly as that. So it's just easier to do it that way. Remember landmarks for injections, a chromium process for your deltoid. Fourth finger, it'll hold up to 1 ml. That sheet I gave you that kind of gives you the average. Usually average for a average size person is a 1-inch length needle, 23 gauge for an IM injection. The vastus lateralis up to 2 mLs, 2 landmarks. Your patella. Would you give me that torso back there, please? So your one hand above the patella, palm on the greater trochanter, point your thumb and index finger together, come right there. So that outside middle quadrant. And I was telling some of them, if y'all look at the mama mannequin over there, she has the little pad for the right on the vastus lateralis. So you can kind of eyeball. And then the ventrogluteal is for right-handed people. If you're on the right side, palm on the greater trochanter, thumb toward the groin, index finger toward the as is, anterior superior iliac spine, middle finger, middle of the iliac crest, between your second and third finger. And usually what I do is just put my little alcohol pad right there, slide my hands down, clean, and I know exactly where I'm going to give the injection. Left-handed people on the right side, you still put your palm on the greater trochanter. Pinky is toward the groin. Fourth finger toward the as is. Middle finger toward the iliac crest. And then you would do it between the third and fourth fingers with your dominant hand. Okay? Thank you. Okay, NG. Any more questions about injections? I'll try.
I'm gonna upload mine to the group. So
Oh, yeah. Okay. Okay. Thank you.
I always, did y'all get the other one I sent? Those, okay.
My kids do better than me.
They've been watching it.
Usually about 25, 27, something like that.
It's about the same.
It's kind of like sub-Q can be anywhere from 27 to 31.
Yeah.
Average for an IM is 23. Some people are 21, 23, 22 gauge.
You can come over here.
On thick medications, sometimes you have to pull it up with thicker, like an 18 or 19, and then please remember to change it. Just don't give it with an 18 or 19.
Excuse me.
Okay, so remember when you do validations for NG, this will already be all set up. You don't have to tell how it's hooked up, how this all gets hooked up. So the NG tube, you've got this, and I'm sorry, I'm gonna borrow this. And remember, somebody was, asking about if you could put a towel here and put all your stuff here. Really not a good idea, because if your patient starts having a seizure, moves, vomits, it's gonna be all over that. So, did you take my,
What you need?
alcohol? That's okay, here, I'll pretend.
Here it is.
Okay, I'm just gonna,
Leave me.
you're okay.
Or just throw
You're-
away.
I'm just gonna pretend that, this is my lubricant. I do need tape. Ooh. Anybody need a wig? Okay, is that a wig? I guess it's Miss Grimes wants to be somebody else, maybe. Is there tape over there?
don't like those doors.
Yeah. So, but when you do get your stuff off of the supply cart, this will be in its own little package. This will be in its own little package on the floor, and this will set up. I'm gonna take now. I'm gonna go ahead and put my gloves on. I'm gonna get to your small knees. Okay. So remember, I go in, I check my order, I talk to my patient, I check the armband, I ask them their birth date or name. That'll be my second identifier. I explain to her what the doctor's ordered. I'm gonna go get the equipment, and then I come back in. One of the first things I'm gonna do is take my pen light and look in both of the nares to decide which way. Remember, on all our mannequins, we have to go down the right. Ask them if they've had nasal surgery, deviated septum, look at that. And then I kind of let them know that I'm going to have them do different precisions with their head, but, it is uncomfortable. It should not be painful. So then I'm going to get all my equipment, I'm going to put on my gloves. I'm going to go ahead and, you'll see nurses put tape everywhere. I see nurses put tape on their scrubs, which grosses me out because you don't know what's all sprayed up there. I've seen them put them here, which is okay as long as you clean it. I'd rather clean it and put it here rather than here. Sometimes when I open up my packaging for this, I'll put my tape on the little plastic part, and sometimes I'll squirt my little jelly on that little opening too. You can also put it on your gloves, because especially if you just put them on. So remember, I'm going to have one piece that's going to split, and you'll more likely have zip tape. This is paper tape because it doesn't stick too well on people. So I've got my NG tube, I've got my piston syringe, I've got my lubrication. Also, that's my lubrication. That's my alcohol swab. And then, how am I going to measure?
From the xiphoid, tip nose to the xiphoid process.
Tip, and again, you don't put it on the nose, but tip of the nose to the bottom of the ear,
And then to the side,
end of the xiphoid process. That's correct. So about right there. This morning I got this one almost all the way down. Let's see if I behave again. What I do with the tape, because if you put tape right together, it's hard. I just kind of fold those ends.
We used to call that dog ear.
So that
Dog
way
ear
you
tape.
can just pull it, you can just do it like this. Much easier. So that's where I need to go to. So then, I've got all my setup done. I've got them sitting up in what position? High Fowlers.
Yeah.
High Fowlers, which is, 90 degrees or as close to 90 as I can get it. I'm gonna lubricate how many inches?
2 to 3 inches.
Hmm?
It was like 2 to 3
2 to
inches.
4.
2 to 4. 2 to 4 inches. So I'm gonna lubricate 2 to 4 inches. I'm gonna have the patient start with their head back on the pillow, kind of open up the throat. I'm gonna have my assistant over on the side with a glass of water or ice chips to help. Remember, you want this on the curved edge. You don't want to insert it like that because it's going to hit the back of the nose. So you want it curved down. Once that gets started, and then they get to a point, they are going to cough. You stop. That's at the back of the oropharynx. So then you're going to have your assistant. They're either going to take a sip of water or the ice chips, and as they swallow, you are going to progress the tube down. You're not going to do this to a real patient. Okay, when you hit the oropharynx, then what do you tell them to do?
Lean forward.
Lean, of course, chest not to, but yeah, you want them to lean forward. As they swallow, you insert. When they stop, you stop. Because remember, when they swallow, it's closing over, and so you cannot, it's less likely you're going to go down. Now, if you start meeting resistance from that point, you would take your pen light, you would look with your pen light to make sure it's not coiling in the back of the the oral pharynx. Then, if the coughing should lessen after you start going down and they start swallowing. If it doesn't and they start getting in respiratory distress or they get some cyanosis around their lips, you need to take the tube out. If they're not, maybe they're just, I've had a patient try to put down and they're vomiting, but they weren't in any kind of respiratory distress. I would just kind of wait till I didn't take it out because I'd already gotten past the bad point. So I would just, kind of leave it. So then you're going to go down till you have your little tape. Okay, so we're just going to say he's not going to go any further right now. So we're going to say that we're there. I'm going to take my piece of tape and I'm going to put, of course I would have my other glove on too, but put that across the bridge. Again, they've probably been sweating. You would need to wipe the bridge so the tape will stick. And I'm just going to kind of go around one way and then go around the other. Just seat it down. Okay. Then, before I do anything else, I'm going to check my placement, right? So one thing I can do is to take my piston syringe. I can pull out 5 to 10 milliliters of gastric contents. And then I could squeeze that on a piece of litmus paper and check my pH, which should be between what?
0 and
1 to 5. 1 to 5. Mm-hmm. Yeah, pretty much anything over 5.5, you're further down in the stomach. There is, I know it talks in your skills book about checking the CO2 level when you're putting it down, not on a regular floor usually. They might do that in the unit. I've never done that, but the other way you can do is to pull back 20 to 30 mLs. This is the least reliable, remember?
Is that the whooshing sound?
And this is where you put the diaphragm of your stethoscope over the stomach area and just do a quick and you'll be able to hear the air in there. The only way to 100% know, again, is the x-ray. So say we've gotten the call back, x-ray says it's in the stomach, so now we need to hook up. Remember, this is the air vent. That's the little valve part right there. But that always needs to be clear, bless you.
Say that one more time. I'm sorry. Say that one more time.
This is the air vent.
Okay.
So there's a little valve right here that needs to always be clear. So the only time you're never going to aspirate stomach contents from the air vent, you're never going to put tube feeding down the air vent. The only time if any stomach contents or tube feeding comes back and clogs that area, you can push a little fluid through the air vent to clear. Okay, so we've gotten the report back, it's in. We are going to connect to our suction, and again you have to have that little connector adapter. And I'm going to turn this on, and remember the needle should be between 0 to 80. And then what I do, again, I know the book talks about a pin. You'll see people talk about pinning here. That's just so dangerous to me, having a safety pin. So I will tape it here on the side. You don't want it down real low, especially if you've got somebody that's pulling at things. But you don't want to pull it so tight that it's rubbing. You also have to remember to do skin assessment every shift, and also oral care in there. Taking it out, you would just turn off your suction. You would unhook. You could leave that open, or you could, since you're taking it out, you could put that right there. You would take your tape off. You're going to have the patient take a couple big breaths, have them inhale and hold, and when they do, you have your other glove and you let's have it curling it. If it doesn't have any blood or anything on it, you can throw that in the regular trash.
That's it.
Okay, and when you take it out, they don't have to be up at high Fowlers. They can actually be in like a semi-Fowlers. Yes.
As far as the taping goes, do we have to do the wraparound, or can we do like a kind of like a butterfly technique like they do with the IVs? Like rip the tape and then just curl it and bring it back upwards.
Be fine, yeah.
I just
mean,
want it as long
as
as
long
it
as it
doesn't
would
obstruct
stay.
the nares. As
Yeah.
long as it doesn't obstruct it. From
Yeah,
like,
now a lot of the hospitals now are using these, little strips
Mm-hmm.
that you can put across there, and that the tube actually, I think, locks, or you can, I've never used
I don't
the
know, they put
strip.
one on Mama that was, they put it, the little butterfly strip, like,
Uh-huh,
they just put it like right there and then they wrapped it around and
Uh-huh.
it was stuck.
Whatever holds it in place
Yes.
without obstructing,
Because I just feel like
without
it was-
inconveniencing.
when I
Yeah.
because I did it both ways, because I don't know, it's just very natural. Anytime
Yeah,
I have a
that'd be
ripped
fine.
piece of tape, it's always just very natural for me
Yeah.
to just loop it. So
whatever's easier, just as long as it's, you know,
as
not
long as
like,
it's secure and it's not obstructing.
Mhm.
And that's all, right? Just making sure, okay.